Okay, so we are going to talk in this talk, which is part 2 of problems of pregnancy and delivery, primarily about preeclampsia, as that is a very common problem that we encounter on labor and delivery. So that is going to be the focus of this lecture, and we'll end with a little bit about amniotic fluid embolism also. But in terms of preeclampsia, first of all, it's important to know that over the last year or two, there have been changes in the definition of preeclampsia after a national task force met to address preeclampsia. So, as in the past, you can assign the diagnosis of preeclampsia if you have a blood pressure of 140/90 and proteinuria of at least 300 milligrams in 24 hours. However, you no longer have to have proteinuria. If you have the designated blood pressure and one of these other criteria, platelet count less than 100,000, elevated liver transaminases, elevated serum creatinine, or the development of pulmonary edema or visual or cerebral disturbances, then that will also give you the definition of the diagnosis of preeclampsia. Also, in terms of definitions, it has been recommended that the term mild preeclampsia not be used, and instead that you will use the terms preeclampsia in the absence of severe features and preeclampsia with severe features. Now, in terms of preeclampsia with severe features, the blood pressure criteria remain the same: a systolic of 160 or greater, or a diastolic of 110 or greater while the patient is on bed rest. So if they have those blood pressure ranges, that makes them preeclampsia with severe features. Most of the other criteria that could also be used to establish the diagnosis of severe preeclampsia remain, including the thrombocytopenia, evidence of impaired liver function such as elevated liver transaminases, or a patient with persistent right upper quadrant or epigastric pain, evidence of progressive renal insufficiency as shown by rising serum creatinine, or the development of pulmonary edema or cerebral or visual disturbances. Any one of those criteria will give the patient the definite diagnosis of preeclampsia with severe features. But you need to note that there is no proteinuria criteria for severe anymore. Used to be if you had 5 grams in 24 hours of protein, that made you severe. No longer the case. Also, they have gotten rid of the fetal intrauterine growth restriction as a criteria for preeclampsia with severe features. Also, as a result of this task force, it's been recommended that there be an emphasis on distinguishing between early and late onset preeclampsia, with early onset preeclampsia being any patient who develops the disease before 34 weeks gestation, late onset 34 weeks or greater. The reason that it's recommended that these diagnoses be distinguished is because the two groups of patients have differing risk factors, and also outcomes are different. Those with early onset preeclampsia are more likely to have worse outcomes for both the mom and the baby. In terms of epidemiology of preeclampsia, it's quite common. It affects about 7.5% of all pregnancies worldwide. In the U.S., it's a little bit less than that, but still about 3 to 5% of all pregnancies in the United States are complicated by preeclampsia. Also, it's concerning that there's been an increase in the prevalence of the disease, especially severe preeclampsia, not so much preeclampsia without severe features or mild preeclampsia. It remains a leading cause of maternal mortality in the U.S. and around the world. Another piece of information to be aware of in terms of epidemiology is that patients will not develop preeclampsia until they're at least 20 weeks gestation unless they have a molar pregnancy. You can establish the diagnosis at less than 20 weeks if it's a molar pregnancy. This graph nicely shows how specifically severe preeclampsia, which is the diamonds, as well as chronic hypertension and gestational hypertension over the past several years has continued to rise in prevalence. You will note that what they term here mild preeclampsia, that would now be called preeclampsia without severe features, has been relatively stable in terms of its prevalence, but not surprisingly, as the incidence of chronic hypertension has increased, that of severe preeclampsia as well as gestational hypertension has increased. And this is a nice graph from the World Health Organization showing how preeclampsia remains a leading cause of maternal mortality worldwide. You can see here it's sort of the orangish, which is the third leading cause of maternal mortality. And I will mention that the number one leading cause, which is in the blue, is pre-existing conditions, and that's all pre-existing conditions. So if you looked at just specific different medical conditions, you may see preeclampsia rise up to being perhaps even the second most cause of maternal mortality. So who's at risk for preeclampsia? A whole list of patients, but nulliparous women, older women, those who are African American race, prior history of preeclampsia or family history, those who have underlying medical conditions such as obesity, chronic hypertension, and diabetes have an increased risk. And then aspects of the pregnancy itself can put a person at risk for preeclampsia, specifically if it's a multiple gestation or a molar pregnancy. In terms of the obstetric management, it's important that we understand what the OBs will be planning to do. And as you probably remember from medical school, the definitive treatment for preeclampsia is to deliver the fetus. However, you need to weigh the risks of delivery of an early fetus with the risk of continuing the pregnancy in a patient with preeclampsia in the mother. And so generally the recommendation is that patients who have what we refer to as mild disease or now preeclampsia without severe features, if the fetus is preterm, that those patients be managed at bed rest unless their condition worsens. In the past, the traditional teaching was that if someone develops severe disease, that this mandated expeditious delivery regardless of gestational age. You would maybe wait for a couple days to get steroids in, but then you would proceed to delivery. That teaching has really changed over the last few years, and now obstetricians are much more likely and willing to allow expectant management of women with severe disease if they do have a significantly preterm fetus. As long as the woman is not getting sicker, they will allow expectant management until either the fetus is older or the mother gets sicker. Another major component of the obstetric management is control of blood pressure. And this is another area where over the last few years, management has changed. It used to be, like back when I was a resident, that they would only treat really severe range blood pressures. Systolics of 160 or sometimes even higher, they would wait to treat it, and diastolics over 110, because the thought was that if they were too aggressive with treating the maternal hypertension, that they would compromise uteroplacental perfusion and end up with a compromised fetus. However, studies now have shown that there is no more adverse outcomes for the fetus, and the outcomes for the mother are better if we treat hypertension that's moderate or greater. So you will now see obstetricians treating systolic blood pressures of 150 or greater and diastolics of 100 or greater. Most commonly used drugs to treat hypertension and preeclampsia are labetalol and hydralazine. Those are really the preferred drugs. And usually the goal is to lower your mean arterial pressure by about 15 to 20%. You generally don't want to go much below that because then you are concerned about effects on uteroplacental perfusion and the fetus. Another important part of the obstetric management of preeclampsia is magnesium sulfate therapy. For preeclampsia, this is used for seizure prophylaxis. It can cause some transient vasodilation and transient decrease in blood pressure, but it should not be looked upon as an antihypertensive. It is given solely for seizure prophylaxis, and in the setting of a preterm fetus, they will also give it for neuroprotection for the fetus. Now, it's important to understand magnesium sulfate therapy, how it can affect the patient. So generally, the therapeutic range for a woman with preeclampsia is to have a magnesium level of 4 to 6 milliequivalents per liter, which is obviously significantly higher than what's considered within normal range of a patient who's not getting mag therapy. As you get higher up, if you get a level of anywhere from 5 to 10, you can start to see some EKG changes, which will include a prolonged PR interval and a widened QRS. Once you get up to a level of about 10, you can have depressed or even absent deep tendon reflexes. And in fact, rather than routinely sending mag levels, one way that they commonly will follow the patient to make sure the level is not getting too high is to assess DTRs and make sure they're still present. As you get even higher, up to 15 milliequivalents per liter, you can see significant respiratory depression or even arrest, and start to see also some other heart blocks, SA and AV node block can occur. And then finally, when you get up to 20 to 25 milliequivalents per liter, you can actually see cardiac arrest. So keep that in mind. It'd be very unusual to get those high levels with the magnesium sulfate therapy that is used for preeclampsia. When these do happen, it's usually iatrogenic, that there was a problem in calculating the dose and the patient got an overdose of magnesium. So from our anesthetic standpoint, that's our major concern. How do we take care of these patients as anesthesiologists? So first thing we need to do is a thorough pre-anesthetic assessment. And as I'm sure you're aware, airway evaluation is key. As we mentioned in our Physiologic Changes podcast, you can see some airway edema just in normal pregnant patients, but you will expect to see even more airway edema in the preeclamptic patient, which can distort the anatomy and make intubation more difficult. The thing to remember too is that the exam can change over time. If you have a preterm woman with preeclampsia who's being kept on the labor and delivery floor for several days, and now they've decided it's time to deliver her, you cannot count on the airway exam from 2-3 days ago. You need to look at the airway exam now, because there have been cases where an airway has gone over a period of time in a preeclamptic patient from a class 1 Mallampati airway up to a class 3. Assessment of fluid status is also important in these patients. Urine output is helpful, as is hematocrit, so you don't want to see a really high hematocrit. If you do, you're concerned that the patient is intravascularly depleted, and the majority of patients with preeclampsia are actually hypovolemic. However, these patients, it's kind of a balancing act, because these patients are also at higher risk for pulmonary edema due to the fact that they have a lower colloid oncotic pressure than a non-preeclamptic patient, and they also have increased pulmonary capillary permeability as a result of their disease. And so although the majority of these patients are intravascularly depleted and actually need some volume, you need to try to distinguish between those who need the fluid versus those who are getting on the borderline of developing pulmonary edema. Usually, though, you can do this clinically. In the vast majority of patients, you do not need invasive monitoring to assess the patient's fluid status. So when would invasive monitoring be needed in a preeclamptic patient? Well, as with any sorts of procedures, you need to weigh the risks and benefits. There may be times where very careful blood pressure control is necessary, and you might place an arterial line. But in terms of central catheters, either a PA catheter or a CVP, the bottom line is there's no study that has demonstrated improved maternal outcome with a central catheter in place. But there may occasionally be a setting where it may be useful to have central monitoring. And that may be the patient who's oliguric and has been unresponsive to a bolus, with the concern being that if they're oliguric, you don't want to put them into pulmonary edema by giving more and more fluid, so you put the central line in to let you know whether or not this oliguria is due to the patient being hypovolemic and requiring more fluid. Also, if a patient develops pulmonary edema, generally the management is going to be diuresis, but if they continue to have pulmonary edema and are unresponsive to that diuresis, that is another setting in which you would consider placing a PA or central line. Coagulation status is another very important component of our pre-anesthetic assessment of the patient with preeclampsia. And the results of that are going to be very important in terms of deciding what type of anesthetic plan we are going to have. So thrombocytopenia is really quite common in the preeclamptic patient. It affects about 15 to 30% of preeclamptic patients will have thrombocytopenia as defined by a platelet count less than 150,000. Now, what's a clinically relevant platelet count is going to be somewhere less than 100,000, even lower than that actually. But the good news is that the majority of preeclamptic patients with thrombocytopenia do not get that low. Less than 10% of preeclamptic women will have a platelet count that drops below 100,000. But it's mandatory, I believe, to get a platelet count in any woman in whom they are talking about the diagnosis of preeclampsia before you go ahead with any sort of neuraxial anesthesia. And what about how often should you have a platelet count? This is going to depend on the patient. If you have a patient with preeclampsia without severe features who's been stable, a platelet count within 24 hours I think is fine. Now, if you have a patient with severe disease or worsening disease that they've now decided that we need to go ahead and get her delivered because she's getting sicker, in those patients there is concern that you can see relatively rapid drops in platelet count. So in those patients, I recommend that you have a platelet count from anywhere from 4 to 6 within the last 4 to 6 hours before going ahead with neuraxial anesthesia. What about other coagulation studies? Do we need to do coags, PT, PTT? I will tell you that back when I was a resident, we got PT, PTT on every single patient with the diagnosis of preeclampsia. The reality is, though, that DIC is rare in patients with isolated preeclampsia, no other conditions like an associated abruption. And it's actually been shown in some retrospective studies that virtually the only patients that you're going to see abnormal other coags, like a prolonged PT, PTT, are going to be in those patients who already have thrombocytopenia. There have been a couple of retrospective studies that have found that. So I would not get coags in someone unless if they had thrombocytopenia, then I would consider also getting coags just to make sure there's not any other underlying coagulation problems going on before I decide to do a neuraxial technique. So this is just another study that again looked at abnormal coagulation studies in patients with preeclampsia. And the one caveat here is that, again, they only saw thrombocytopenia in patients who had abnormal coags being, had either thrombocytopenia, or the other thing was abnormal liver function, elevated LDH. So in all other cases, they didn't find any significant abnormal coagulation results. Any mild changes that they saw were not clinically significant. So again, primarily you want to get coags in the patients who have either thrombocytopenia or abnormal liver function. So you look at the platelet count. Is that all that you need to do? There have been some studies that suggested that in women with preeclampsia, they may have abnormal platelet function, regardless actually of their platelet count. Now, this hypothesis was drawn from studies that used a bleeding time to assess platelet function, and it's since been debunked as an effective test. It's unreliable. So for the most part, I don't think we need to be assessing platelet function, but you may want to consider using something like a TEG or PFA 100 to assess platelet function in those patients who have the borderline platelet count. They're like right around 70,000 maybe, and you'd really like to have an epidural, but you're a little reluctant. It may help you with your decision making to look not only just at your platelet count, but to look at how well the platelets you have are functioning, and to do something like a TEG or a platelet function analyzer test. So then that brings up the question, since we're worried about thrombocytopenia in these patients, you know, how low is too low in terms of doing neuraxial anesthesia? And the answer is, I'm not going to give you an absolute cutoff. I don't think that that's appropriate. I think that for each patient, you need to weigh the risk of developing an epidural hematoma with the benefits of providing epidural analgesia or anesthesia, both for the mom and the fetus. So what do we know? We know that epidural hematoma in preeclamptic patients is actually quite rare. Only 1 or 2 case reports. So we talk about it all the time, but it's really quite a very rare complication. And just to show you this was a retrospective study that looked at 2,900 women, and they found that among those 2,900 women, there were 14 women who had platelet counts that ranged anywhere from 15 to 99,000 who received epidural analgesia, and none of those 14 women had any sort of neurologic sequelae as a result of having a neuraxial procedure performed at a low platelet count. Jake Bayland at Mount Sinai did a study several years ago where he looked retrospectively, and again, he found even more patients, 30 patients who had platelet counts not as low, like 69 to 98,000. None of them had any sort of neurologic complications. And I would say most of us, the 70 to 100,000, we're not going to blink twice anymore about doing a neuraxial technique in those obstetric patients. Another retrospective study looked, those other ones that I just mentioned were all comers who were pregnant. This was a study that looked specifically at preeclamptic women with thrombocytopenia. And I think that's important because, again, since there's been some suggestion that possibly there's a component of platelet dysfunction also in the preeclamptic patient, in his retrospective study, he found 62 patients who were thrombocytopenic who'd received either spinal or epidural anesthesia for cesarean delivery. And again, had some patients with very low platelet counts, as low as 19,000. But again, no epidural hematomas or any other neurologic complications in any of those over 60 patients who received a Neuraxial technique with a low platelet count. So as I said, I'm not going to give you an absolute cutoff of when to do or not do regional anesthesia. I think there's some things you need to do. Look at the patient carefully. Are there any signs of coagulopathy? Because obviously if she has any clinical signs, you're not going to want to do Neuraxial. I do recommend, if your platelet count is below 100,000, to also get coags, PT-PTT, before you decide to do a Neuraxial technique. But you need to assess each patient's individual risk for general anesthesia. Now, I am willing to go lower in terms of platelet count and doing Neuraxial in the patient who I'm really concerned about general. So they're 400 pounds and have a class 3 airway. I'm going to go lower with them than I am with the patient who is 120 pounds with a class 1 airway. Generally, especially in preeclamptic patients, I'll perform regional anesthesia if the platelet count is 70,000 or greater, provided that there has not been a rapid decline. You know, if it's 70,000 and 6 hours ago it was 200,000, then I'm not going to do it. And I will, in some of these patients, consider performing TEG or PFA 100, but there are lots of benefits to having Neuraxial anesthesia in preeclamptic women, so I may actually be willing to go somewhat lower in terms of doing Neuraxial with a low platelet count with a preeclamptic patient as compared to someone maybe without preeclampsia but ITP. So now that we've talked about, you know, what's going to prevent me from doing Neuraxial in terms of thrombocytopenia, let's move on to the use of labor analgesia in the preeclamptic patient. So there are many advantages of epidural analgesia in these patients. Obviously, you get great pain relief. As a result of that pain relief, it's been shown in preeclamptic patients that you actually reduce circulating catecholamine levels associated with the pain of labor, so that's a benefit. Also, it avoids the need for general anesthesia if you have to do an emergency cesarean delivery in these high-risk patients. And that's going to be not just the airway issues that we talk about in all of our parturients, but also concerns about severe hypertension as a result of responses to laryngoscopy and intubation. So those are some of the advantages. There have been people who have said we should really think very carefully about doing epidural in preeclamptic patients because there are some disadvantages there. One is that with the fluid preload that we give, we could put these patients who are at risk into pulmonary edema. The other is that if we cause hypotension with our epidural, we're going to precipitate significant fetal compromise. So those have been disadvantages suggested by some obstetricians and anesthesiologists. The reality, though, is that scientific studies have refuted these concerns. You know, if you're careful with your fluid management, you're not going to put the patient into pulmonary edema, and there's no evidence that these women are more likely to develop fetal distress as a result of epidural-induced hypotension than a non-preeclamptic patient. In terms of looking at outcomes of labor, this was a nice study. It was a large multi-center study that assessed the safety of epidural analgesia in patients with severe preeclampsia. Now, I would tell you this is a secondary analysis of a prospective randomized study. So it is a secondary analysis. But importantly, they found no difference in either the overall C-section rate or C-section for fetal compromise between severely preeclamptic women who had epidurals and those who did not have epidurals during their labor. There also, you know, again, this refutes some of the purported disadvantages. There was no difference in the incidence of pulmonary edema in the patients who got epidural as compared to not having epidural. What about the effects of epidural analgesia on the fetus? So, you know, some people suggest, oh, you're going to make mom hypotensive, you're going to make things worse. Well, in fact, the scientific evidence that is out there would suggest that having an epidural in a severely preeclamptic patient is actually advantageous to the fetus. A study from many years ago showed that with ultrasound that there was improved intervillous blood flow in severe preeclamptics who received epidural labor analgesia. A more recent study looked at a more accurate measurement of placental function, looking at uterine artery systolic to diastolic ratio with ultrasound, and they were able to show that this was improved in severely preeclamptic women to the point where actually the uterine artery systolic to diastolic ratio was reaching levels that are near what's considered normal in a non-preeclamptic parturient. So actually can be beneficial to the fetus also to have an epidural in place for pregnancy. And as a result of that, the ACOG put together a task force on hypertension in pregnancy a couple years ago, came out with a report, and they are on our side in terms of having epidurals in these patients with preeclampsia. They recommended the use of neuraxial anesthesia for both labor analgesia and cesarean delivery in hypertensive preeclamptic patients, and stated in this report that the quality of evidence to support that recommendation was moderate, and as a result, the strength of this recommendation was a strong recommendation. So clearly, OBs and anesthesiologists agree that epidurals are good in these patients. Now, should we manage these patients any differently when we're doing an epidural? Well, you do need to be a little bit careful about your fluid bolus. You don't want to put a patient into pulmonary edema. Generally, what I would do, I think, as you know, our usual non-preeclamptic patients will usually give somewhere around 1 liter bolus. With the preeclamptic patient, I won't give more than a 500 cc bolus, and then I'm going to watch and see what happens. In terms of epidural test dose, there has been some controversy about using a test dose with epinephrine in a preeclamptic patient, especially a severely preeclamptic patient, with the concern being that if you use a test dose with epinephrine and in fact your epidural catheter is intravascular, that in these already hypertensive patients that you could precipitate severe hypertension with that test dose. So I think that you need to be careful. I would consider using a non-epinephrine containing test dose in someone who I'm starting out who's already got severe hypertension. But if they've got blood pressures in the mild range, I don't worry about using our usual 1.5 lidocaine with epi test dose. I think it's important to watch these patients carefully, maybe a little bit more slowly dose the epidural, still use the same low concentrations that we use of our local anesthetic, and then watch blood pressure closely, of course. But I'll use the same sort of infusion, but just slowly dose it, watch the blood pressure. If I've only given a 500 cc bolus and I'm starting to see a decline in blood pressure, I might give a little bit more fluid. And then what else am I going to do in terms of treating the hypotension if it develops? Well, first of all, you need to realize, you know, many of us think of, oh, I got to start treating the blood pressure when the systolic gets below about 100. Remember, these patients are starting out at a higher baseline, so you need to know what their baseline was before you get started, and then you want to treat any significant drops from the baseline. So rather than having a set number, know what their baseline is, and once you start to see anywhere from a 20 to definitely 30% drop from their baseline, then you want to be pretty aggressive about starting to treat any drops in blood pressure, because you do know that in this disease you already have a component of compromised uterine placental perfusion, and you don't want to do other things like significant hypotension that's going to even further compromise uterine placental perfusion and the fetus. So any drop, 20 to 30%, if you see even smaller drops and you're starting to see changes in the fetal heart rate, I think you should also be aggressive about treating those drops in blood pressure also. And this is going to be, you know, with IV fluid bolus if the patient isn't, you know, showing signs like a decreasing SAT or or shortness of breath or symptoms suggesting she's developing pulmonary edema, and then vasopressors. One thing to understand is that the preeclamptic patient is going to have an increased sensitivity to your vasopressors, so you need to begin with small doses. You can always give more, but you can't take back what you've given. So, for instance, if I'm using phenylephrine in a preeclamptic patient, I'm probably going to start out with no more than a 50 mic bolus. If I'm using ephedrine, I'm probably going to start out with no more than 2.5 or 5 milligrams. What about the use of a combined spinal epidural in preeclampsia? Well, there certainly could be some advantages. As you know, you get great pain relief and rapid pain relief with minimal motor block. Because you're using predominantly opioid, you're not going to have a significant sympathectomy, so you might be less likely to cause hypotension compared to an epidural dose with local anesthetic. On the other hand, there are disadvantages, as we talked when we talked about labor analgesia and anesthesia for C-section. When you do a combined spinal epidural, you give your spinal component, you don't know for sure that that epidural catheter is functioning until the spinal has worn off and you've dosed the epidural. Now, in the vast majority of cases, it's going to work. I mean, you got CSF back through your spinal needle, so you seem to be in the right place. But occasionally something goes awry as you were threading that epidural catheter. So you are in this situation of, as long as that spinal opioid is working and the patient has good pain relief from that, you don't really know 100% that your epidural is going to function. If during that time period something happens, that the baby goes into is compromised or something else, that they decide they need to do an emergent C-section, you're going to be dosing an epidural that hasn't been tested yet, and there's a small chance that it won't work, and then you'll have to do a general anesthetic in that emergent situation. So those are disadvantages of that. So how do I handle CSE in the preeclamptic patient? Well, if I have a patient with, mild disease, no severe features, and she's doing fine, blood pressure's looking good, baby's heart rate, the fetal heart rate tracing looks okay, and she's really hurting, she's, held off, didn't want an epidural, now she's 8 centimeters, I think it's reasonable to do a combined spinal epidural in that patient for sure. And I would dose it in the usual way that I would dose any combined spinal epidural, 20 to 25 mics of fentanyl, usually with either 1.25 to 2.5 milligrams of isobaric bupivacaine. I would avoid combined spinal epidural in certain preeclamptic patients for labor. And that would be those who already have a concerning abnormal fetal heart tracing. I know they're more likely to ultimately go back for an emergent C-section, so I want an epidural in that I have dosed and I know is working fine. Also, if I suspect she's got a difficult airway, she's big, she's got a lot of facial edema, or if she has severe disease, that's going to put her at higher risk ultimately for an emergency C-section. So those patients, I would avoid doing combined spinal epidural for labor analgesia. So that management of labor analgesia in the preeclamptic. Now let's spend some time talking about anesthesia for C-section in these patients. So there's going to be several advantages of doing regional neuraxial anesthesia over general anesthesia. That includes the usual, that you avoid the aspiration risk, you avoid risk of a difficult airway, but especially important in these patients is that you avoid the hypertensive response to laryngoscopy. That is a unique advantage of doing neuraxial versus general in these patients. It's been shown that epinephrine and norepinephrine levels are increased during cesarean delivery in preeclamptic patients when you use general anesthesia, but not regional anesthesia. There's also been evidence of an increased risk of stroke when you use general anesthesia. Epidural anesthesia has, so if you're going to do neuraxial anesthesia, are you going to do epidural or spinal? So there can be some advantages of epidural. One is that you can dose it incrementally and then maybe avoid any sort of hypotension that could be detrimental to the fetus. However, as with any parturient, there are definitely advantages to a spinal, one being that you get a more reliable block. Also, if it's in a setting of fetal compromise, you may be able to quickly get a spinal in and avoid general anesthesia, but you won't have the time to do an epidural. So in those urgent situations, there's an advantage of a more rapid onset with a spinal. And then in that thrombocytopenic preeclamptic patients, they got that borderline platelet count, 70, 80,000. although there isn't any studies to show any difference in outcomes, you would never be able to do it. It would have to be a huge study to show it. It certainly intuitively makes sense that there's going to be less trauma to the epidural space with a small 25 gauge non-cutting spinal needle than with a 17 gauge epidural needle. So in those patients, I think you should consider doing a single shot spinal if you think it will last long enough for your surgery. There's actually been quite a few studies that have looked at the use of epidural versus spinal anesthesia in preeclamptic patients and looking at outcomes. This was one of the earliest ones where this author did a randomized prospective study in which he compared women with severe preeclampsia for C-section. And these were non-emergent C-sections only, not ones who were having stat C-sections. And he compared those who had epidural, spinal, and general anesthesia. And he found, first of all, the concern about, dropping the blood pressure with a spinal. There was no difference in the lowest blood pressure obtained with the 3 different types of anesthesia. There was no difference in APGAR scores or umbilical artery pH, so no significant difference in outcomes for the neonate. There have also been other studies that certainly support the use of spinal anesthesia in severe preeclamptics. And you may think, why are you making a big deal about this? We do this all the time. Well, yes, we do, but I would tell you that when I was a resident, we were taught that you don't do a spinal anesthetic in a preeclamptic because you're going to bottom out her blood pressure and you're not going to be able to treat it effectively, and you're going to have a baby that's not doing well. But in fact, the studies that have been done over the last 10 years or so have shown that actually the risk of developing spinal-induced hypotension is less in preeclamptic patients than it is in normotensive patients. So this would definitely support that. And then doing spinal anesthesia. Now, I will tell you there was one randomized prospective study that did report a higher incidence of hypotension in preeclamptic women who got spinals versus epidurals. But again, you got to look at your numbers and decide, is this clinically significant? Because first of all, you see the hypotension, you're aggressive with treating it, as I told you should. And what did they find? The mean duration of hypotension in these patients was no greater than 1 minute. And the bottom line is your concern about the hypotension is the effects on the fetus. Well, they looked at umbilical artery pH, which is the best indicator we have of fetal status after delivery, and there was no difference in umbilical artery pH between those who had spinals and those who had epidurals. So I think that the evidence clearly supports that you can safely do a spinal anesthetic in a severe preeclamptic, and in emergent situations and in situations where you're considered about the trauma from the needle in a thrombocytopenic patient, a spinal may be your preferred anesthetic. So, spinal versus epidural. So, as I mentioned, spinal anesthetic is going to be preferred when you've got fetal distress. You don't have time to do an epidural. When you have that thrombocytopenic patient. Now, in non-urgent C-sections, I think either technique is acceptable with similar outcomes. It's whatever you prefer. Now, so we would rather do a C-section under spinal anesthesia or epidural anesthesia rather than general anesthesia in a preeclamptic patient. However, we know that there are times when you simply can't do it. You have a coagulopathic patient. Her platelet count isn't 70,000, it's 30,000. I think you're not going to find many anesthesiologists who are willing to do a neuraxial technique in that case. She has all of a sudden acute severe fetal compromise, does not have an epidural in place, and we need to get this baby delivered, and we need to get this baby delivered now. Clearly, inducing general anesthesia is faster than trying to do any sort of neuraxial technique. And occasionally you have a patient who refuses to have regional anesthesia. In those situations, you are going to have to do general anesthesia. So what do you need to consider? Number one, you need to realize that the leading cause of maternal death in women with preeclampsia is intracranial hemorrhage, stroke. And of course, hypertension is a major contributing factor to the stroke that leads to the maternal death. And so you've got to be concerned about preventing any sort of hypertensive response to your laryngoscopy and intubation. And in fact, there was a recent population-based study that showed that the risk of stroke in women with severe preeclampsia undergoing cesarean delivery is greater in those who have general anesthesia as compared to neuraxial anesthesia. So that's why we like to do neuraxial, but as I said, there's times that you cannot avoid doing general. You need to keep that in mind. You need to do whatever you can to prevent any sort of severe hypertension. So you have the patient who has to have general anesthesia. First, a careful evaluation of the airway. Hopefully this patient you knew about before all of a sudden they're rushing back for a C-section. You've looked at her airway, but even if it's someone that's just arrived in triage, severe range blood pressures, and now the baby's got bradycardia and they say we have to go now, you take the time to look at that airway, evaluate that airway before you do anything else. Aspiration prophylaxis as with any other patient. If it's not a stat case, because we're so concerned about avoiding severe hypertension with our induction, I would recommend seriously consider placing an arterial line to monitor beat-to-beat blood pressure if you have the time. And that might be the case of patient has HELLP syndrome with a low platelet count, baby's looking fine, but we need to get mom delivered. That's a situation where you might put an arterial line in. If you suspect a difficult airway, consider either an awake intubation or a video laryngoscope for your intubation. Again, as I said, you're concerned about airway edema, so you want to have small endotracheal tubes immediately available. In the normal pregnant patient, we usually use a 6.5 tube, never more than a 7.0. I preferentially use a 6.5. You want to have 5, 5.5, 6 available in these severely preeclamptic patients, and especially if you see that they have a lot of facial edema. I can remember a patient that I had once many years ago at another institution. It was like Christmas Day, I think, of course. She was really sick. Her face was so swollen. Her eyes were, she couldn't close her eyes. They were so swollen. And in fact, we could only get a 5.0 endotracheal tube in. So have small tubes available. Realize that you may have difficulty with the airway, so have alternative airway devices available, such as an LMA, and definitely have a glide scope immediately available. And I would probably say with the preeclamptic patient that I'm doing a general on, this might be the patient where, regardless of what their airway exam looks like, that I might just go straight with the glide scope for my laryngoscopy. In terms of your induction of general anesthesia, of course, it's going to be a rapid sequence induction. You want to do something in terms of pre-treatment to prevent hypertensive response to laryngoscopy. And this was a nice review article that was in A&A a couple years ago with this nice table of various strategies that you can use to blunt the hypertensive response to intubation. So some labetalol, some esmolol, some opioid, especially remifentanil is very short acting, so you don't have to worry much about its effect on the baby. Nitroglycerin, nicardipine are other options. So just, you need to realize in terms of your choice how quickly it's going to have an onset and how long it's going to last. But this is a nice table to have as you think about that. Now, in addition to that, so you're pre-treating to prevent that hypertensive response. Now it's time for actual induction. These patients, propofol, excuse me, propofol is going to be your preferred induction agent. Etomidate, ketamine, they are not going to do anything in terms of blunting your hypertensive response to laryngoscopy, and in fact, they don't blunt the sympathetic system, and so you could see severe hypertension. So the only time in a preeclamptic patient undergoing general anesthesia that I would use either of those drugs would be if in the setting of not only is she preeclamptic, but she's maybe had a major abruption and she's hemorrhaging and she's hypotensive as a result of her blood loss. Otherwise, I would use propofol. Succinylcholine is going to be my muscle relaxant of choice. And what about continued magnesium sulfate during the C-section? It is recommended to continue it. Sometimes the obstetricians may ask you to stop it, especially if they have concern about atony. But again, that task force from ACOG, they recommend continuing the magnesium sulfate during C-section with, again, quality of evidence being moderate and the strength of recommendation being strong, because you don't want the patient seizing on you on the OR table. Now, if need to understand the effects of magnesium as it relates to your anesthetic, because even if the obstetrician asks you to turn the magnesium off at the beginning of the case, if it's been going for several hours, you're still going to have a significant magnesium effect during that anesthetic. So to review, the effects of magnesium sulfate, MAG inhibits release of acetylcholine at the neuromuscular junction. As a result, it also decreases the sensitivity of the neuromuscular junction to acetylcholine. So we know that it potentiates all of our non-depolarizing muscle relaxants. So if you're going to use a non-depolarizer during the C-section in the preeclamptic patient on magnesium, you need to use small doses. Start out with, half of the initial maintenance dose that you might give someone, and then carefully monitor them with a nerve stimulator. You can always give more if you need to, but if you give a big whopping dose and they're done quickly, you may be sitting there with a patient who's not reversible as a result of that magnesium. Now, what about effects on your succinylcholine? Well, we know that with a usual single dose, that it does not prolong the onset or the duration of succinylcholine. And so you should use the usual intubating dose of 1 to 1.5 milligrams per kilo, because a single normal dose of succinylcholine is not going to be significantly affected by that magnesium sulfate. What about concerns about uterine atony? That's why sometimes they'll ask you to turn off the magnesium. In fact, in studies, there has not been, it's not been shown that there's increased blood loss in preeclamptic women receiving magnesium compared to those not receiving magnesium. But you may occasionally have the patient with uterine atony, and that for other reasons, they develop uterine atony. They've got an infected uterus, multiple gestation, twin delivery, something like that, because we know that patient's at higher risk for preeclampsia. But the magnesium certainly is not going to be beneficial in terms of trying to get that uterus to clamp down. So just be aware of that, and certainly would want to have uterotonic agents available. But I will caution you, as when we talked in our obstetric hemorrhage talk, that ergot alkaloids, methergine, can cause significant hypertension. So that would be a relative contraindication to use that for hemorrhage, is the patient who has preeclampsia. Now, you've gotten through your delivery, baby's out, looking good, surgeon's closed, you're getting ready to wake up. What things do you need to consider at emergence? Well, this is another prime time when the patient, as they're waking up, starting to cough, whatever, that they can get hypertensive. We don't want them getting severely hypertensive because we don't want them having a stroke and dying. And so you want to, again, consider giving agents to blunt that hypertensive response. And some of those same antihypertensives in the table I just showed you, you could consider pre-treating or giving some as the pressure starts to slowly rise in these patients. Also understand that because of airway edema, they're more likely to have some airway difficulties at extubation. So you want to make sure these patients are very awake and responsive before you extubate the patients. And then what about during the postpartum period? First of all, in that immediate postpartum period, continue to watch them closely in terms of concerns about airway difficulties, airway obstruction. Understand that even though they're now delivered, they still are at risk for stroke, pulmonary edema, and seizures. Some people think babies delivered, they can't have seizures. That's not true. You can have seizures, and they'll usually continue MAG for 12 to 24 hours after delivery, because in fact the second most common time to have a seizure related to preeclampsia is in the postpartum period. And that is why postpartum MAG is recommended. The most common time to seize in preeclampsia and now eclampsia is during labor. What about the use of NSAIDs? You will sometimes hear the obstetrician say that they do not want preeclamptic patients to get NSAIDs for postoperative analgesia. And that is because there have been some studies in other patient populations showing increased blood pressure with the use of NSAIDs. There is a recent study out there, though, that found no association between the use of NSAIDs and increased peripartum blood pressure in preeclamptic patients. So personally, I believe it's okay to give NSAIDs. But still, again, close monitoring of blood pressure, treating it, being aggressive, again, using the moderate hypertension as your criteria. So systolics over 150, diastolics over 100, start thinking about treating that blood pressure. Now, let's spend a little bit of time talking about some of the variants of preeclampsia. One is the HELLP syndrome. It's a variant of severe preeclampsia, and I will tell you that patients who develop HELLP syndrome have higher rates of both maternal and perinatal mortality and morbidity. The diagnosis, HELLP, it stands for HE, is hemolysis, which is evidenced usually by increased bilirubin or LDH. And then you have EL, also stands for elevated liver enzymes, and specifically your transaminases. And then LP stands for low platelet count, less than 100,000. And understand that in patients with HELLP syndrome, the platelet count can drop precipitously. So if you put an epidural in a patient developing HELLP syndrome, you better make sure that you check the platelet count again before you pull the epidural catheter. In terms of management of HELLP syndrome, generally, if you're at 34 weeks gestation or greater, the obstetricians are going to say, we need to get you delivered, and there's not going to be any delaying to allow the baby to mature anymore. There's not a good consensus before 34 weeks. There are some obstetricians that feel like these moms are really sick and they need to be delivered despite the fact that they're going to be delivering a preterm baby. There are others, though, that will wait and get at least to get the antenatal corticosteroids in and at 24 hours after that. There can be two benefits to that. One benefit is that you get the effect for the fetus in terms of pulmonary complications. You get that benefit if it's a preterm fetus. But this was an interesting study that came from just down the road at Central Baptist, that the anesthesiologist there, in conjunction with our Dr. O'Brien, who used to work down there, did a study, and they also found that with the steroid administration and then waiting 24 hours after the steroid administration to go ahead and deliver the baby, they mostly did this for the advantageous effects of the corticosteroids, but they did find that another outcome of doing that was that they saw increases in platelet count, and therefore more women who got the steroids were able to have epidural anesthesia as compared to those who didn't get steroids. So there are some that will go immediately and deliver, many who will get antenatal steroids in at least and wait 24 hours after the steroids. And then there are some who are willing to sit and wait for several days, frequently following labs, and delay delivery as long as they can, especially if it's a very preterm fetus, until the mother gets sicker. Now, eclampsia, that's new onset seizures or unexplained coma in a patient who has signs of preeclampsia and no other pre-existing neurologic disorder, so they don't have a seizure disorder, whatever. The incidence in the developed world is decreasing. In the U.S. now, it's only about 0.8 per 10,000 pregnancies. So most of you will go through residency and maybe much of your practice without ever seeing an eclamptic patient. It still is it's more common, of course, in the developing world. So who's at risk for eclampsia? Young women, so those who are less than 20, those who are nulliparous, patients with multiple gestations, molar pregnancies, if they have pre-existing hypertension or renal disease, if they have lupus, or if they've had a previous history of severe preeclampsia. These patients are at higher risk for developing eclampsia. How does it present? Generally, the seizures will occur most commonly during labor and delivery, and that is why you may have someone with preeclampsia sitting on the floor preterm. They're not going to deliver her yet, and she's not on MAG. But once they decide to start induction or that she goes into labor, they will start the magnesium, and that is because that's the most common time for seizures to arise. The next most common time is in the first 48 hours postpartum, and that is why magnesium is continued. But realize that it can occur, just like preeclampsia itself, can occur up to 4 weeks postpartum. So you can have someone come in postpartum who's seized and has eclampsia, just like you can have someone come in postpartum with a new diagnosis of preeclampsia. It presents generally with a generalized tonic-clonic seizure, but generally short, usually lasts about a minute or maybe even less. Oftentimes these patients will have some premonitory signs such as headache, blurred vision, hyperreflexia, you commonly see, and they may have some altered mental status. In terms of the mechanism of these eclamptic seizures, it's not well understood. It's felt that it may involve the loss of normal cerebral autoregulation that leads to cerebral hyperperfusion, and then that progresses on to cerebral edema and decreased cerebral blood flow. So neuroradiologic studies in the recent have shown, based on what the brain looks like on imaging, is that eclampsia is actually a form of posterior reversible encephalopathy syndrome, or otherwise known as PRES. And you can also have patients with preeclampsia who have some, who don't have seizures but have some mental status changes, who also on radiologic imaging are diagnosed with PRES. In terms of the management of these patients, the number one thing, of course, is controlling the seizure. So most commonly, benzodiazepines are used. You need to think about airway management. It's rare that you actually have to intubate the patient because, as I said, they're usually short seizures, especially by the time you give some drugs, the seizure is gone. So you usually don't have to intubate the patient, but you certainly want to manage the airway. Then they will try to prevent further seizures by starting magnesium sulfate. And when a patient presents with eclampsia, expeditious delivery is required. However, that doesn't mean you need to run back and do a stat C-section right now. Sometimes with the seizures, you'll see fetal bradycardia, but once the seizure stops, the fetal bradycardia will quickly resolve. So that doesn't mandate that you do a stat C-section. As I said, in many of these patients, once they've had the seizure, it's treated, they've started magnesium sulfate, it's actually reasonable to consider labor and a vaginal delivery if they think this is a labor that's going to progress relatively quickly. They're not going to attempt, probably in a preeclamptic patient, a labor induction in someone who has a closed and thick cervix. But if they have a favorable cervix, they're already starting to contract some, they may attempt a vaginal delivery. As long as there's no current signs of increased ICP and the patient has a normal platelet count, you can offer Neuraxial Analgesia for labor and Neuraxial anesthesia for C-section in patients who've had eclampsia. So that's a bit about preeclampsia and its variants, and then I wanted to spend just the last couple of minutes talking about amniotic fluid embolism. This is a rare event in pregnant women, but the problem is it's often fatal. Anywhere from 50 to 80% mortality has been reported. Need to understand that for an amniotic fluid embolism to occur, there are two things that need to be present. First, there has to be rupture of amniotic membrane. So a woman's not going to have an amniotic fluid embolism if her membranes are not ruptured. And then there has to be a site of entry for that amniotic fluid into the maternal circulation. Maybe some sort of a cervical laceration or just some, mild trauma from the dilation of the cervix. As you know, there's oftentimes bleeding, mild bleeding associated with cervical dilation. So those are the two things you need for an amniotic fluid embolism to occur. How is the patient going to present? Generally, they will present all of a sudden onset of dyspnea, sudden drop in O2 saturation. From there, they usually have significant cardiovascular compromise with the development of hypotension, sometimes even full cardiovascular collapse and cardiac arrest. So that is sort of phase one of your amniotic fluid embolism. If they survive this initial vent, which is going to be over 15-30 minutes or so, they may, over time, over the next hour or so, develop other problems, including left ventricular failure and DIC. So you have that initial phase one over 15-30 minutes, dyspnea, desaturation, cardiovascular collapse. And then from there, you go on to the phase two where you can get left ventricular failure and DIC. So in terms of the pathophysiology, what happens? Now, this is not a mechanical embolism like you think of a pulmonary embolus with a clot. What happens is the amniotic fluid gets into the pulmonary circulation and causes an intense vasospasm. We're not sure why. It seems like probably the women who develop this have something abnormal about their amniotic fluid. So they get that intense vasospasm that causes sudden pulmonary hypertension and cor pulmonale, so right-sided failure, and you'll see that on echo. They also have a deranged ventilation perfusion ratio, and they get hypoxic and tissue ischemia. And then over time, about 40% of them will develop DIC. They also have an increased risk of uterine atony, and they can also get left-sided heart failure over the next hour or so also. In terms of the management of amniotic fluid embolism is wholly supportive therapy. There is no way to prevent it. The treatment is solely supportive. They're going to need intubation and ventilation. They're going to need rapid and aggressive resuscitation, which will usually include not only fluid resuscitation, but inotropic support, will generally need invasive monitors, art line, usually central line also. And then if they're part of the 40% or so who develop DIC, on top of everything else that's going on, you're going to have to deal with that with transfusion of blood products. And so that is preeclampsia and amniotic fluid embolism. So that's the end of second part of the lecture, problems in pregnancy and delivery. I would tell you there's many other conditions that can occur, things to think about, like what's associated with problems with multiple gestation, etc. But I felt like the best thing to do was to really focus on an in-depth discussion of those problems that you are most commonly going to see, which is the obstetric hemorrhage and preeclampsia. Thank you.